Hello, and welcome to the workshop, Major Treatment Decisions for Patients with Acute Myeloid Leukemia, or AML. My name is Sue Stewart, and I'm an AML and 33-year transplant survivor, and the founder and the executive director of BMT Infonet, who's your host for this webinar. I'd like to thank Synnex Pharmaceuticals, whose support helped make this presentation possible. And now it's my pleasure to introduce to you our distinguished speaker today, Dr. Fred Appelbaum. Dr. Appelbaum is the Executive Vice President and the Deputy Director of the Fred Hutchinson Cancer Center. He's the past chair of the Board of Scientific Advisors of the National Cancer Institute and is a member of the National Academy of Medicine. He has served as a board member on numerous scientific societies, including the American Society of Hematology, the American Society for Clinical Oncology, the American Association for Cancer Research, and the American Society for Transplantation and Cellular Therapy. Dr. Appelbaum is head of the Hematologic Malignancies Program at the Fred Hutchinson University of Washington Cancer Consortium and the principal investigator on several National Institutes of Health grants. He's the author of over 900 scientific articles and was the lead author on the first paper to describe the successful use of autologous marrow transplantation. In the early days of transplantation, Dr. Appelbaum worked closely with Nobel laureate Dr. E. Donald Thomas, who pioneered the use of bone marrow transplantation to treat patients with blood cancers. Dr. Appelbaum's current areas of research center on the biology and treatment of hematologic malignancies, especially acute myeloid leukemia. Please join me in welcoming Dr. Fred Appelbaum.
Thank you, Susan. It's a pleasure to be here to discuss acute myeloid leukemia, which is, after all, a remarkably dramatic and difficult disease. It often comes out of the blue and therefore is a shock often for the patients and their families. And as I stated, it is really a very dramatic disease. It occurs in about 21,000 new cases in the United States every year. That's not as common, of course, as something like breast cancer or prostate cancer, but 21,000 is a lot of people. And if it's not treated, unlike breast cancer or colon cancer, where people can live for months to years with the disease, if AML is not treated, it is fatal within weeks to months. Therefore, early treatment and appropriate diagnosis are incredibly important in managing acute myeloid leukemia. The disease is really one that shows a dramatic increase as patients get older. If people are younger, on this slide you can see from the time from birth until about 50 years of age, the incidence of AML stays fairly constant at about 3 to 4 patients per 100,000. But once patients pass age 50, the incidence of the disease goes up dramatically. Now that's in contradistinction to ALL, acute lymphocytic leukemia, which is really much more commonly a disease of childhood with a peak incidence at around 5 to 7 years. And thereafter, its incidence actually goes down and stays fairly constant over the rest of life. In AML, on the other hand, there is this dramatic increase as one passes the age of 50. And that's thought to be likely due to the accumulation of mutations in the hematologic system with time. And that isn't too different than the increase in other cancers. This looks a lot like the incidence of colon cancer that goes up as you get older, lung cancer, and prostate cancer as well. Well, why do people develop AML? First off, there are increasingly a number of genetic predisposition syndromes that we've been able to identify. Some years ago, we used to think that AML was by and large a spontaneous disease, but more and more as numbers of patients who are being followed with the disease increase, we're finding that it does, in some cases, tend to run in families. Now, there are 3 different kinds of genetic predispositions that we've identified. The first are what are called pure leukemia syndromes, and that is that you have an aunt or an uncle that has acute myeloid leukemia, and a cousin that has acute myeloid leukemia, and someone in your family develops acute myeloid leukemia. And it's not associated with other problems, it just is a pure leukemia syndrome. And there are several of those, for example, one that's called RUNX1. There are also some syndromes where it's not just leukemia, but there's overall marrow failure, and these are characterized usually in childhood, things like Black-Van-Diamond syndrome, where patients develop aplastic anemia or marrow failure and then go on to develop acute myeloid leukemia. There are also some syndromes where there's multiple problems beyond leukemia, that the patients can develop other kinds of malignancies as well as leukemia. A classic example of that would be the Lee-Fraumeni syndrome. And then finally, there are some diseases like Down syndrome, chromosome 21 trisomy, where there's lots of developmental problems along with acute leukemia. But overall, if you look at the total incidence of acute myeloid leukemia, genetic predisposition probably still only accounts for maybe 10% of cases, if that. Much more commonly are these other causes. We know that radiation can cause acute leukemia. If we look at survivors of the atomic bomb blast in Hiroshima and Nagasaki, 7 years later there was a dramatic increase in the incidence of acute myeloid leukemia. People that have a history of smoking, particularly heavy smoking, probably double or triple their incidence of acute myeloid leukemia. And exposure to certain solvents, like benzene, have been associated with acute myeloid leukemia. Now, OSHA, that is the governmental agencies responsible for making sure that workplaces remain toxin-free, have really decreased the incidence of these sorts of leukemias by getting benzene exposure out of the workplace. Now, two other causes of AML are being increasingly experienced. The first is prior chemotherapy. As individuals are now surviving diseases such as lymphoma, where they are treated with an alkylating agent and an anthracycline, or adjuvant chemotherapy for breast cancer, or Hodgkin's disease, what we're seeing is that there is an increased incidence of them developing subsequent chemotherapy-induced AML. It usually comes on 5 to 7 years after the exposure to these drugs, but there are a few cases where it can come on as early as 18 months in certain circumstances. The broad term we use for those AML are called treatment-related AML, or TAML. We'll talk a little bit more about that later. There also are individuals who have myelodysplasia, which is a low-grade myeloid malignancy that can go on for quite a few years, or other myeloproliferative disorders like polycythemia vera or essential thrombocytosis. After a number of years, some of these more indolent myeloid malignancies can suddenly turn into acute myeloid leukemia. We call those secondary AMLs. Now, treatment-related AMLs and secondary AMLs have a lot in common, and so sometimes they are lumped together when talking about AML etiology. But we do sometimes distinguish them, as I've just described, with treatment-related being responsible, those that are responsible for prior exposure to chemotherapy, and secondary AMLs being those that follow myeloid dysplasias. Whatever the cause of AML, the clinical symptoms are pretty much the same. Classically, people will be fatigued, and that's because they are anemic. And without enough red cells being produced by the disordered bone marrow, there's not enough oxygen being carried to the muscles in the brain, so that people will be fatigued. They will not have the same exercise tolerance that they used to have. They will be needing naps, and generally all the classic signs of anemia. We also see thrombocytopenia, that is not enough platelets in a lot of our patients, and so that leads to the problems of bleeding and bruising. Oftentimes, because of AML, you will not produce enough normal granulocytes. These are the cells in the peripheral blood that fight bacterial infections, and because of that, you can see fever, you can see non-healing infections of the skin, sometimes of the gums. So fatigue, bleeding, and fever are common manifestations of acute myeloid leukemia, and occasionally the acute myeloid leukemic cells can get together and form a mass underneath the skin oftentimes. It's usually non-tender and soft, and those are called chloromas. But whatever, in order to make the diagnosis, one needs to show that there are leukemic blasts either in the peripheral blood or in the bone marrow. Oftentimes, the peripheral blood is enough to make the diagnosis if there are more than 20% blasts. And I'll tell you what a blast is. I'll show you a picture of a blast in just a second. But a blast is the word that we use to describe a cell that is obviously an AML cell, a leukemic cell. Now, if there aren't enough blasts in the peripheral blood, then we need to do a bone marrow aspirate biopsy to make the diagnosis. And either in the peripheral blood or the bone marrow, we need to have 20% or more blasts to call it AML. Now, whether we do the diagnostic procedure on the peripheral blood, if there's enough blasts there, or whether we do it on the bone marrow, there are four major ways that we look at those leukemic cells. One of them is called morphology. That's just looking down a microscope. A second is something called immunophenotyping, which is also called flow cytometry. A third is cytogenetics, and a fourth are molecular studies. If someone has undergoing an evaluation for acute myeloid leukemia, it's really important that all four of these categories of tests be done. Now, I have to say that up until a few years ago, frequently there would be patients who would be diagnosed with AML, oftentimes in outlying hospitals where this was not routinely done. More recently, through education, including things like the BMT Infonet, the word has gotten out, and so it's much less common that patients don't have good diagnostic studies done at diagnosis. So this is what we're talking about when we talk about an AML blast. And if you look at that picture, there's this cell in the corner, which has a dark blue central area. That's the cell nucleus. And surrounding that is a grayer area. That's called the cytoplasm. And then the other things that you see in that little picture are red blood cells. An AML blast has a very large nucleus filling up most of the cell. And the reason the nucleus is so big is that AML cells are dividing rapidly, and the nucleus is the site of all the DNA. The DNA has to replicate before a cell can divide, and because there's so much DNA replicating, the nucleus gets very large and fills up most of the cell. And so that's what an AML blast looks like. That's the evil guy that's causing all the disease. Now, when you can see it like this, it's pretty easy to identify that as an AML blast. But when you see it in a sea of cells, it's more difficult. And quite frankly, you can sometimes pathologists disagree about whether a cell is a blast or not, even if you have 2 or 3 different pathologists look at it. And so morphology by itself is pretty imprecise. It's also not very sensitive. Normal individuals can have 1 or 2% AML blasts or blasts in their bone marrow that are not diagnostic of AML. You need some young cells, after all, if your bone marrow is going to keep dividing and forming new cells. And so 1 or 2% is normal. 6% is probably getting into the abnormal range, but you need 20% to make the diagnosis of AML. And so morphology by itself is how we used to make the diagnosis. Now we have other techniques which are more precise and more sensitive. And the second way that we do that is through something that's called flow cytometry. Now, I'm showing you this because not that I expect you to become a flow cytometrist, but only to know what the doctors are looking at when they say they need to do flow cytometry. And what they're doing is they're looking at 10 different markers on the surface of a cell. Each one is labeled with a different color fluorochrome that lights up when a laser hits that cell. And this is just a remarkable technology. What they're doing is they're having cells come through a capillary tube at 10,000 cells a minute. They have a laser hit each one of those cells. That cell lights up, and any one up to 10 different colors light up on that cell, and then those are sorted. And so imagine if you wanted to describe a person, and you wanted to say, well, let's look at their height versus their weight. You could look at that in 2 dimensions. And then let's look at their skin color versus their hair color. Then let's look at their muscle mass versus their fat. And by looking at all these different parameters, you eventually can get a fingerprint of that individual, which is unlike any other individual in the entire city. And that's what this does. With flow cytometry, we're able to get a fingerprint of the leukemia, which is unlike any other cell in the body. And because of that, we're able to detect leukemia down to a range of 1 in 1,000 or even 1 in 10,000 cells in the bone marrow. Now, this is important for 3 reasons. Number 1, it is reproducible, and so it establishes that this is, in fact, acute leukemia and not something else. Number 2, the different fluorochromes that light up tell us something about prognosis. And so if you have a lot of, for example, CD33, that's a little better prognosis than if you have very little CD33 on the cell surface. And finally, after you are treated, you may look like your bone marrow has gone back into complete remission, but with flow cytometry, we can still detect some measurable residual disease, something called MRD, and that can be very useful in guiding further therapy. So that's the second thing that we use as a marker for leukemia in diagnostics. The first being morphology, the second being flow cytometry. This is the third. This is cytogenetics. Now, each of us have in all of our cells 46 chromosomes. 23 that come from mom and 23 that come from dad. And so you have pairs of them. You have 2 chromosome 1s, 2 chromosome 2s, 2 chromosome 3s, etc. Now, if you stop a cell before it gets ready to divide, the chromosomes, they bunch up and they look like these little worms. And then you can stain them. And so not only do they look like little worms, but they look like little worms that have these black marks across them. And those are very reproducible and distinct for normal chromosomes. And now here the cytogeneticist has done us the favor of lining up each of the chromosome 1s and each of the chromosome 2s. And so you can see, are all the chromosomes there? And are they all looking normal? Well, sometimes in acute leukemia, you may lose a chromosome, or you may gain a chromosome, or you may have a chromosome that is broken. And sometimes when they break, one piece of a chromosome goes from one chromosome to another. And here you can see that there is a change where part of chromosome 8 has gotten stuck onto part of chromosome 21. So that's called a translocation between 8 and 21. Now, the reason that looking at cytogenetics is important, it's not very sensitive, not nearly as sensitive as looking, for example, at flow cytometry. But it is important because, first of all, it is often abnormal. Second, it's very important in prognosis. And so patients that have the 821 translocation, for example, have a good prognosis with acute myeloid leukemia, whereas those that have many more cytogenetic abnormalities, something that's called complex cytogenetics, have a very poor prognosis. And thirdly, historically, it's been really important because if, in fact, there's often the same recurrent break from 8 to 21, it suggests that maybe at that site of 8 and 21, there's a gene that's important in the regulation of myeloid cells, and maybe that explains how leukemia develops, and that, in fact, has turned out to be the case. So cytogenetics is important because it's prognostically very important, and in addition, it has been a great teacher about the way that leukemia develops. Now, what those genes are that are actually broken are shown on this slide, and these are so-called recurrent mutations in AML. As we have gotten better at being able to sequence the entire DNA of individuals, we have been able to find those genes which are recurrently mutated in AML. Now, we didn't have any idea how we could do this 20 years ago. But with the development of high throughput sequencing, we now can do this very inexpensively and very effectively. And so now we always look to see which genes are mutated in a patient's AML. In a single AML case, usually there's about 12 different genes that are mutated in a person's AML. Now, 6 of those are what we call passenger mutations and have nothing to do with the leukemia. They just are random things that have happened in that cell. But 6 of them are related to the development of AML. And it takes probably a sequence of them to develop before you get overt AML. And so you can have a mutation in one gene, let's say DNMT3A is one of them, and the cell still functions quite normally. You don't even notice that it's abnormal or hardly notice it at all. It might be like driving in a car and the shock absorbers aren't working quite well enough. The ride might be a little bumpy, but the car still works just fine. But with time, that bumpy ride can cause a second problem. For example, it can cause the brakes to start to fail. And now the ride might be a little more abnormal. And then further, if it goes beyond that and you start, because of all that shaking, the throttle becomes abnormal and the gas pedal can get stuck, you can imagine that suddenly you have a real problem. You can't stop your car. It's going too fast as you careen down the road, and suddenly you have acute leukemia. Now, we look at the genes that are mutated in AML, and we do that by sequencing. And this is really important because it tells us both the characteristics of the leukemia, that is it a good or bad prognostic leukemia, and more importantly, it can guide therapy because with certain of these mutations now, we have therapies that are targeted specifically for those mutations. And the classic here is FLT3, which is probably the most frequently single mutated gene in AML. And we now have a drug that helps specifically with FLT3 or FLT3 mutated AML. Now, if we put all these things together, that is the morphology, the cytogenetics, the flow cytometry, and mutations, we classify AML into 3 large categories. Those that are called favorable risk, and these include those that have the translocation 821 or inversion 16, those that have a mutation in NPM1 but not FLT3, and those that have the mutation in this gene called CEBPA. Then there's the broad category of intermediate risk AML, and finally there is the bad actors, the ones that are adverse, that have complex cytogenetics or abnormalities in P53 and a few others. Now, when I say favorable, intermediate, or adverse risk, really what we're talking about is what happens if you just treat the patient with standard chemotherapy and the patient is under, let's say, age 65 and can get full dose therapies. And with those kinds of caveats, our favorable risk AMLs have a cure rate without transplantation, which is well above 50%. But those with intermediate or adverse risk disease, if just treated with chemotherapy, do much more poorly. Adverse risk AML without transplantation, if just given standard chemotherapy, in fact, are probably cured in no more than 15% of cases or so. And so that makes it different. So that means that because what we expect with conventional chemotherapy differs, our subsequent management of those patients is influenced by whether they're favorable, intermediate, or adverse risk. So I'm going to pause at that point and just summarize what I've said so far, that acute leukemia is an explosive disease, that in order to diagnose it, we need to have people look at the blasts that are either in the peripheral blood, if it's over 20%, or the bone marrow, and that they need to be looked at by morphology, by flow, by cytogenetics, and by mutational analysis. Now, once all that's done, we're ready to start treatment. Now, a question always comes up is, well, where should I be treated? I will admit that this study may be viewed as self-serving, but we looked at a large number of patients, over 60,000, and asked, were they treated at an academic medical center that is a cancer center, or were they treated in the community? And by our analysis, which has been reviewed by others, your chance of living 5 years is almost doubled if you're treated at an academic cancer center than if you're treated in the community, and your chance of dying within the first month is doubled if you're treated in the community versus an academic center. Now, I will readily admit that there may be selection bias here. That is, those who are sicker and perhaps older don't want to travel to an academic center and are treated in the community. We did try to do statistical corrections for those risk factors, but you never can be absolutely sure when it's not a prospective randomized study. Nonetheless, if it were me or a loved one of mine, there are certain diseases where you get great care out in the community. I think AML is one where it's such a difficult disease. It needs all the support that you get from infectious disease experts and everyone else, that my advice would be, if you can be treated at a cancer center or an academic center, I would encourage people to do so. Having said that, I also understand that it can be quite an explosive disease, and there may not always be time to arrange for that transfer, but I think that most centers would be eager to try and help that happen. So once you decide to start therapy, what do you do? The first big decision is whether you're going to view the patient as being fit or less fit. And I have to say that that is often in the eyes of the beholder. In general, we view people as being less fit if they have advanced age, and that means over age 70 or 75. And in addition to just being older, they also have comorbidities. Age by itself is not necessarily a significant, overwhelming factor. Certainly it contributes, but there's lots of 70-year-olds who are in good health, out jogging every day without comorbid disease. And on the other hand, there are some 60 or 50-year-olds who've had a tough life with a lot of alcoholism or smoking or obesity, diabetes, where they may not be as fit as the older individual. In general, if we view a patient as being fit, then the first thing we do is we treat them with induction chemotherapy, and that's an attempt to get the disease into a complete remission. And we'll talk about what standard induction is in just a second. If patients are felt to be not good candidates for induction therapy, then we may treat them not at all. That is, just give them blood transfusions in hospice if they are very sick, because treating someone who's 85 or 90 who has lots of comorbidities may just not be the right thing to do, and supportive care may be in their best interest. A clinical trial, of course, is always something that's of interest for really anyone that has acute leukemia, and there are now less intense regimens that are being used, and being used with increasing success. And in fact, this is probably one of the bigger advances in the treatment of AML, is the improvement in some of these less intensive therapies for patients who are not candidates for induction chemotherapy. Now, if you do treat with induction chemotherapy, then at the end of induction, we reevaluate the patient, and based on how that induction therapy went, we then decide what subsequent steps to take, and we'll discuss that in just a minute. So what is induction chemotherapy? Induction chemotherapy, the standard induction chemotherapy for quite a few years now, has been a combination of two drugs, an anthracycline, like donomycin, idarubicin, or mitoxantrone, along with cytosine arabinoside, or Ara-C. There are other recipes that people use. Frequently, people use higher dose cytosine arabinoside in regimens such as FLAG-IDA, something called IA, or GCLAM. Always, if a patient is willing, studies are being done looking at better induction regimens, and if patients can get on a clinical trial studying these, we always encourage that, as long as the patients are well informed about such trials. Now, while standard regimens have been cytosine arabinoside and an anthracycline, there have been three changes over the last few years. The first is that if patients have favorable or intermediate risk disease, then we would generally recommend adding gentuzumab ozogamicin, a so-called Mylotarg, to the 7-3 regimen. And this is based on several prospective randomized studies which have shown an overall survival advantage to the addition of gemtuzumab ozogamicin plus 7-3 versus 7-3 alone in patients who have intermediate and good risk AML. If patients have FLT3 positive AML, then we recommend adding mitoxantrone to the regimen, which is a specific inhibitor of FLT3. And then if patients have treatment-related or secondary AML, we would consider using CXP351 instead of 7-3 based on prospective randomized studies. Now, what is the outcome of this therapy? Well, the best outcome, the one we long for, is that you get a complete remission without MRD. And remember, I told you that MRD stands for measurable residual disease that we can detect using flow cytometry or more recently by PCR. So this is the preferred outcome with induction chemotherapy, that you recover your blood counts and we cannot find any residual disease using these sensitive techniques. If we don't measure MRD, we can just call it globally a complete response. And this means that you've recovered your blood counts and that we don't see circulating blasts, but MRD is either positive or unknown, so that we would lump as CRs. There's something called CRI, which means that you don't see blasts, but your counts haven't recovered very well. And unfortunately, a CRI does not predict for as good an outcome subsequently as if you get a CR or a CR without measurable residual disease. And then these are responses that are less than a CR, and unfortunately, these don't help you in the long run very much. These mean that induction therapy has largely failed. Well, what do we do after induction chemotherapy is done? It depends, of course, if a patient is good risk, intermediate risk, or poor risk, as we talked about. For favorable risk AML, we do not generally recommend transplantation in first remission. These patients can be effectively treated with multiple cycles of high-dose Ara-C-containing chemotherapy, and we generally reserve transplantation until first relapse. Now, we sometimes do transplant favorable risk AMLs if they have measurable residual disease still after induction, or if the disease went away and we see recurrence of measurable residual disease, then we would definitely recommend transplanting patients, even though they have favorable risk AML, transplanting them in first remission. For intermediate risk AML, in general, we recommend an allogeneic transplant in first remission if an appropriate donor is available. Now, by appropriate donor, this definition has widened dramatically over the last few years. Many years ago, it was only a matched sibling, and then when we started being able to develop these large registries of donors with over 40 million people typed around the world, finding matched unrelated donors became possible for many individuals. More recently, cord blood and even the use of haploidentical transplants has broadened what we would define as an appropriate donor. So for most people with intermediate risk AML, we would recommend transplantation in first remission, unless, of course, they have comorbidities which make transplantation more dangerous, and that would be a comorbidity index of greater than 2, and if they are MRD negative. So if a patient gets into complete remission and is MRD negative and has comorbidities, then perhaps in some of those, we might hold off doing the transplant. But for the most part, if patients get into CR, and whether or not they have MRD, as long as they're relatively healthy and have a good donor for intermediate risk, we would recommend transplantation in first remission. And finally, for advanced risk AML, they do so poorly with conventional chemotherapy that we generally recommend a transplant if at all possible. Now, for patients who have not achieved a complete remission, those patients need to go on to subsequent trials trying to get a first remission with other forms of therapy, with salvage therapies if available. Once you get into complete remission, and if you elect not to have a transplant, then there are some maintenance options. For patients who are FLT3 positive, we do recommend going on midostaurin for 12 months if they do not undergo an allogeneic transplant. If they do undergo an allogeneic transplant, there are now studies looking at the use of FLT3 inhibitors after a transplant to maintain that complete remission. And those studies are not entirely complete, but those that have been done do look encouraging. If patients are not going to a transplant and do not have FLT3 mutated AML, then there are some data that suggest that maintenance with 5-azacitidine may be effective. Now, there's controversy about this. In some studies, it did not look as effective, but more recently, there are studies that show that it may have an effect if used after 2 courses of intensive therapy. And more recently, there's been a new drug called Onureg, which is oral azacitidine, which has been approved for maintenance based on a prospective randomized study that was done. Now, this was done, that study with Onureg was done in patients who were over age 55 who had intermediate or advanced risk disease and were in CR1. Whether it works in younger patients is uncertain. Whether it works in good risk patients is uncertain. It just hasn't been tested in those circumstances. It does have some GI toxicity, and it can lower blood counts. But there are data that suggest it does prolong the disease-free and overall survival. Now, going on to transplantation is much more tolerable today than it was 20 years ago. There have been real advances in transplantation, which I'm sure fans of this program have heard about. Now we find a donor for almost everyone in need, as I already mentioned, using either unrelated donors, cord blood, or haploidentical transplants. We see much less in the way of transplant-related complications. We are better at preventing and treating infections with better antiviral and antifungal agents. We are better at avoiding direct organ toxicities by our selection of preparative regimens, and we have better ways of reducing or preventing graft versus host disease. And likewise, we're doing better at eradicating the leukemia with a transplant. I'm going to show you a slide here that came from our institution, and it kind of summarizes what I just said. We looked at over 1,000 transplants that we performed in Seattle between 1993 and 1997, and this includes all patients that we transplanted for a hematologic malignancy. And as you can see, there was about a 50% survival at 3 years. We then looked at patients we transplanted a decade later, from 2003 to 2007. And the same criteria for entry into the study. And as you can see, overall survival improved dramatically over that decade. And this was largely because we had better drugs for viral diseases, for fungal diseases. We were using more reduced intensity preparative regimens, et cetera. And in fact, between 2003 and 2007, the patients that we were transplanting were older and had more risks than the younger group. So the advantage you see here was really markedly more than that if you had corrected for risk factors. And then if you look from 2013 to 2017, another 1,200 patients that we transplanted in Seattle, again, this improvement. And this continues going on, and I suspect when we look at 2023 to 2027, hopefully we're going to be up here someplace, but time will tell. So transplantation continues to improve. The risks are getting less. It still is a tough and dangerous procedure and not something that we just recommend willy-nilly. It's a tough disease, a tough procedure, but it cures patients who are otherwise incurable. Now, I did mention that we are doing more patients being treated with less intensive induction. And this has been quite an active area of research. These are generally for the less fit patient, and by less fit, again, as I already mentioned, that means that patients are older and they generally have some comorbidities. That is, they have a comorbidity index of 2 or 3, or they have an ECOG performance status of 3 or 4, et cetera. But if a patient is older and is less fit, then there are these regimens that are being explored. Now, these regimens are not designed as curative therapies. They're designed to try and get a person into remission and keep them there as long as possible. And the therapies generally are continually given month after month after month. We don't know about the relevance of MRD when we use these less intensive therapies. And there has not been a really good prospective randomized study comparing intensive to less intensive induction chemotherapy in AML. Such studies are ongoing at the current time, but we do not have the results. If we look back at retrospective analyses, and we recently published a study that included well over 1,000 patients, we just published it in Blood, Mohammed Sor was the first author, it does look retrospectively like intensive therapy benefits older individuals in whom it's given, even if patients are in their 70s and even if they have some comorbidities. But again, that was not a randomized prospective study. Now, the regimen that has gotten the most excitement is that of a combination of azacitidine plus venetoclax. And that result came from the so-called Viale-A trial. And those results are shown in this box, where you have patients who are randomized to the combination of azacitidine plus venetoclax versus azacitidine alone. And the CR rates were the composite CR rates, and that includes CR and CRIs, was more than doubled with the combination of azacitidine plus venetoclax. The median time to response, so you have to give several cycles of the azacitidine and venetoclax, and so it takes 2 to 3 cycles to get into complete remission. And the overall survival, the median overall survival with the more effective arm was still only a little over a year, 14.7 months. By a year, about half the patients had died, even in the more effective arm. So not where we want to be, but better than where we were. Again, the goal here is probably not cure. You just keep giving the therapy as long as possible. And if the therapy fails, unfortunately, after venetoclax, azacitidine failure, survival is very poor. But if you do get a CR with azacitidine venetoclax, there are, even though the patients were deemed as less fit and not able to get a intensive chemotherapy initially, if their overall performance status dramatically improves because they've gotten into remission with azacitidine venetoclax, some of those patients then do go on to transplantation and may be able to be cured in that setting. So I've been talking for a little less than 45 minutes or so. We want to make sure that we have time for answering questions that the audience may have. But I would like to just summarize some of the key points I tried to make during my talk. First of all, the diagnosis of AML generally requires 20% or more blasts, and this can be from the blood or the marrow. That we need to have both morphology and flow cytometry, along with cytogenetics and molecular data, used to risk stratify patients and to follow them once they get into complete remission. In general, we would urge patients to be treated at academic centers, cancer centers, if possible. Retrospective analysis suggests that outcomes are improved. Once patients get into complete remission, other factors that can influence what is done includes their age, their functional status, how well their count recovers after they're given chemotherapy, and whether or not they have minimal residual disease. For fit patients, we generally recommend intensive induction chemotherapy. We add to that gemtuzumab for good and intermediate risk, and midostaurin for FLT3 positive mutated patients. There are these new molecularly targeted drugs that have been FDA approved. If patients do not go into a transplant, maintenance may be appropriate for many of those. We do recommend transplantation for eligible patients who have intermediate or high-risk disease, and for less fit patients, the combination of venetoclax and azacitidine looks remarkably effective compared to what we had available to us in the past. Whether that is superior to intensive chemotherapy is a big unanswered question. And so with that, I will pause. Thank you for attending the webinar. I also need to thank thousands of AML researchers who have been involved in the development of all this information, and of course the patients who have been on clinical trials allowing us to amass this knowledge. And so with that, I will pause and be happy to answer any questions.
Thank you, Dr. Appelbaum. That was an excellent presentation, a great summary of treatment options for patients with AML. So we'll now begin the question and answer session. And as a reminder, if you do have a question, please type it into the chat box on the left side of your screen. You referred several times to a haploidentical transplant. Can you explain what that is?
Sure. So that individuals inherit, HLA is a bunch of genes that are located on chromosome 6. And they're all close together, and so you get one chromosome 6 from mom and one chromosome 6 from dad. Since mom has 2 chromosome 6s and dad has 2 chromosome 6s, the chance that any 2 siblings will inherit the same 2 chromosome 6s is 1 in 4. And so that would be a complete match. We sometimes call it a 8 of 8 match. And that's how we normally were picking donors. But sometimes, you'll have siblings where you will inherit the same chromosome 6 from mom, but different ones from dad. And so you're matched for one of the chromosomes, but not for the other. Those are so-called haplomatches. In addition, everyone is a haplomatch to their mother or father because you inherit one of their chromosomes, 6s, and not the other one. And so it was some years ago almost unthinkable to use people who were mismatched for a whole chromosome 6, and then some investigators, first in Italy, Velarde and company, using a method of T-cell depletion, and more recently, the group from Hopkins using post-transplant Cytoxin have demonstrated that, in fact, you can use donors who are only haplomatches, that is, mothers for children, siblings who inherit only one of the 2 chromosomes from the same parent. Those are haplomatches. And because most people have a parent or a child who might be healthy enough to donate, or a sibling who is a half match, that means that we can now find donors for the vast majority of patients in need. Now, the outcomes with haploidentical transplants aren't quite as good as with fully matched siblings, although the difference between the 2 has been shrinking dramatically over the years. And so now there are some institutions where they would use a haplomatch rather than a fully matched unrelated donor. Now, there's other institutions that haven't made that switch yet. And whether haploidentical transplants are better than cord blood is yet another question. And so the choice of donor between matched SIB, matched unrelated, cord blood, and a haploidentical donor is a hotly debated research topic. But it's much better to have that as a research topic than not to have donors at all.
Great. People who want to know if you can provide some statistics on survival rates for AML patients who undergo the transplant.
Well, the survival statistics for AML for patients who undergo transplantation depends a great deal on the patient, characteristics. That is, are they younger? Are they older? Are they in a complete remission, or do they have minimal residual disease? Are they being transplanted for good risk AML, poor risk AML, or are they getting donors from matched siblings, matched unrelated? So there's a wide range. However, if you take our studies in Seattle and you look at our most recent data for AML for patients age 55 and younger who have been transplanted in first remission, we have a remarkably good outcome with about an 80% cure rate.
That is remarkable. All right, there are a couple people.
I just want to be sure, Susan, that you heard the caveats there. Those are under age 55 who are getting ablative regimens from matched siblings or matched unrelateds. So that doesn't include patients who are 65. It doesn't include patients who have large amounts of residual disease or are getting mismatched transplants. But in that category, things are really getting better and better.
Well, that is encouraging. We have a couple questions about the relationship between age and eligibility for transplant. One person wants to know whether a 76-year-old physically fit person can undergo intensive conditioning safely, and the other wants to know whether age alone determines whether intense therapy is appropriate if there are no other comorbidities.
Oh boy, that's such a good question and such a hard one. As someone who is 76 and would call himself physically fit, this question hits me close to the heart. It's one I do a lot of consults for, and it really does depend on what the patient's life goals are. If you were 76 and had lots of comorbidities, you aren't one who's seeking aggressive therapy, and you have something that you'd like to do in 6 months that's going to be the most important thing in your life, probably I wouldn't recommend a transplant. But if you're 76 and you're healthy and you've gotten into a complete remission, and you have the goal of being alive in 10 years, then yeah, I certainly encourage people to go ahead with a transplant. One thing that's happened is we have developed preparative regimens here in Seattle and elsewhere. For example, in Seattle, we use a regimen which is just fludarabine and low-dose TBI. We can do that transplant as an outpatient, and oftentimes patients never even get hospitalized. Now, they can get into problems with graft versus host disease and infection, and so it's not a walk in the park, and I would never want to tell someone that it is. But it can be remarkably non-toxic in some patients. Just this last year, I was attending on 2 patients who were age 78 and 79, both of whom went through the transplant without major problems. But I've also seen patients, in their early 70s that have quite a few complications. So it's not an easy choice. But in Seattle, we would not rule someone out on age alone up until probably they get to 80 or so.
All right. This person just had a transplant in July. She's a 52-year-old female. She had FLT3, very low ratio. Wants to know a couple things. Would she be considered a favorable risk or an intermediate risk? And she's also commenting that today is day 90. She just had a bone marrow biopsy, and she's wondering if she should be put on a targeted drug for FLT3, and if so, what would it be and for how long?
The studies are not definitive yet, and so for some people would err on the side of commission, that is, and use a drug, and some people would say, well, the studies aren't totally known yet, and so I'm afraid to use it. In Seattle, we would err towards putting patients on a FLT3 inhibitor after the transplant if they had FLT3 positive AML. Now, she said that she was a low allelic ratio initially. Is that right?
Correct.
How low? Well, that's right. I think, again, I want to caution people, I'm not seeing the patient. I'm not reading their chart. I hate to give individual patient advice without actually being responsible for taking care of the patient. So all that, I think those are important caveats. Depending on the allelic ratio, there are two schools of thought where a very low allelic ratio is not considered to be of as much concern as a high allelic ratio. And it also depends on what other mutations the patient has along with the FLT3. So if they're NPM1 negative, for example, then that still is a higher risk than if they were NPM1 positive.
All right. The next person said he or she, I guess he, has been doing well for over a year now on azacitidine and venetoclax, and wonders when you would consider a transplant. Wait till relapse or earlier. He was fit and is 73.
Well, again, if he waits till he relapses, the chance of a transplant working are very low. He's unlikely to get back into a complete remission, and the transplants carried out for people that have active disease just don't do nearly as well. And so if he ever wants to consider a transplant, he should do it while he's in remission. That doesn't mean he should do a transplant. I'm just saying that if he is someone who thinks that they want to have a transplant at some point, they ought to get it while they're in remission. Waiting until relapse, it's unlikely that they'll be able to get an effective transplant because the disease is, once you relapse, it's very hard to get people back in remission after they fail a year of azacitidine, venetoclax. And if you try to do a transplant with active disease, the chance of the transplant working are much, much less.
All right, this next person has a donor question. She wants to know if you're 62 years old and you had a choice between a 12 out of 12 matched related sibling, or actually 64, the sibling is 62 years old and is 12 out of 12 match, or you could choose a 20-year-old who is a 10 out of 10 matched unrelated donor. Any opinion on that?
Yeah, well, there have been probably 6 research articles published about this question, and 3 go one way and 3 go the other way. There's a lot of debate about this, about whether a sibling, an older sibling, or a younger matched unrelated donor. And so I don't think that the answer is clear cut. It also depends on what kind of transplant the person is going to undergo, what exact regimen they're talking about using, et cetera. So there's no easy answer for that one. Each different transplant centers will give you a different answer depending on which study they did.
All right.
Sorry.
The next person, yeah, well, I can understand. The next person wants to know, do you have a better chance of survival if your AML is caught early versus late?
Yeah, we don't know that, to be honest. There is no way to kind of do that study because you don't know if it's caught early or late. What you know is what the white count is at diagnosis, but is that because the disease is growing more rapidly? So, if your count is very high, does that mean your disease was caught late versus early? Now, it does, of course, make intuitive sense that finding it a little earlier when there's fewer leukemic cells should be of some advantage. But that's pretty hard to prove. In mouse models, if you inoculate fewer leukemic cells, you can cure the mouse more easily, both with chemotherapy and with allogeneic transplants. So that would argue that there's some advantage to that. So probably there may be a teeny bit of advantage to catching it early, but we really can't prove that definitively.
All right, the next question comes from a 55-year-old female who had a stem cell transplant from a 100% matched sibling donor, but she relapsed 7 months after transplant. She's now considering a trial using CAR T-cell therapy. Can you comment on CAR T-cell therapy to treat patients with AML?
Yeah, it is, unfortunately, it's been much more difficult to develop effective CAR T-cells for AML than it was to develop CAR T-cells for ALL, CLL, or lymphoma. The ALL, CLL, and lymphoma CAR T-cell studies targeted something called CD19, which was really expressed heavily on the malignant cells, and you could wipe out the CD19 cells, whether they're malignant or normal, without a huge amount of toxicity to the patient. It's surprising, but you can live pretty well without any normal B cells for some period of time. And in addition, the CLL cells and ALL cells just were intrinsically more sensitive to the killing of a CAR T cell. In AML, we don't have that good a target. And so people have been trying to find what is a good target for AML. And unfortunately, most of the targets which people have studied, being probably the 3 most commonly studied ones, are CD33, CD123, and WT1. They're expressed on normal early hematopoietic cells, at least CD33 and CD123 are. And so the studies have been difficult to perform because patients get a lot of pancytopenia with the CAR T cell, and the AML cells don't seem to be quite as sensitive to direct killing. Now, having said all that, the studies that are ongoing with genetically engineered immune cells, CAR T cells or TCR T cells, there's a lot of incredible science that's going into this now. And so there has been a lot of progress, but unfortunately still the difference between CAR T cells for ALL, where it's approved, where there's 4 different drugs out there, for AML, we're quite a ways behind. Nothing has been FDA approved. These are our early phase studies, and the outcomes are pretty uncertain. So I think being involved in such a study is certainly, I would encourage it. I'm sure that the scientists who are doing it are bright people and have lots of good ideas. But I think people have to go in with their eyes open, not expecting to be promised the same kind of outcomes that we've seen with ALL in AML. Hopefully someday we'll be there, and maybe this new approach, whoever this person is being treated, will be that step that allows that to happen. I don't know, but we're still, as far as what's out there in the published literature, what's been presented at scientific meetings, and what we've heard in symposium just a week or 2 ago, we have a long way to go.
All right. The next person has a question about cord blood transplants. To know whether cord blood has to be HLA matched like marrow or stem cells.
Actually not. And in fact, that's one of the really important points about cord blood. Cord blood, when we first started doing cord blood transplants, almost all the cord blood transplants were done, the unrelated cord blood transplants, I should say that there were some related cord blood transplants that were done, but those are almost all for infant or childhood diseases. But for adults, the cord bloods that were being done were all mismatched for 1 or 2 antigens in the vast majority of cases. And surprisingly, we did not see a big increase in graft versus host disease. In fact, if anything, with cord blood transplants, we saw certainly less chronic GVHD than we saw with unrelated donor transplants. So we do cord transplants that are mismatched for 2 or more antigens. And that has been really important, particularly for patients without matched siblings or matched unrelated donors. And of course, as I think most people know, that it's much harder to find a matched unrelated donor for people from ethnic minorities, whether it be Hispanic or Black, or certainly people of mixed racial background. Now, the reason for that is it's an interesting story of anthropology. Modern humanity began on the African continent, and so there were, just every HLA type is represented there. With time, populations of individuals left and carried only a subset of HLA types with them. And so there are HLA types that are pretty homogeneous within certain populations. For example, among the Japanese, there's a small number of HLA types comparatively, but there's just much more heterogeneity in African individuals or people in the United States of African descent, similarly among Hispanics. And so just with all that heterogeneity, it's tougher to find a matched unrelated donor, which makes cord blood an important source of stem cells. Now, with the development of haploidentical transplants, though, many people are starting to favor haplo over cord, although whether that's really the right thing to do is still, I think, debatable. They do have, each has its own advantages and disadvantages in particular situations.
All right. This person has a question about what is considered full recovery of blood counts after a stem cell transplant. For example, only 4 years ago, he had a transplant, and his platelet count currently hovers around 150 or slightly less. Other blood counts are not too bad. He's considered immunocompromised by the oncologist, and he wonders, is that considered full recovery of blood counts, or does he need more?
I'd have to know more about the specific patient. A platelet count of 150,000 is just fine, and that would be considered normal, and that in and of itself wouldn't by any means represent any kind of compromise in function, either immune or blood clotting or anything else. So 150,000 platelets is great. Now, there might be something else going on. That is why the doc is calling him immunocompromised, but it's not a platelet count of 150,000.
All right. We have 3 questions. We'll try to squeeze these in. This question I actually don't even understand, but I'm sure you will. The gentleman wants to know when TET2, TET2 is present. Does that pose a problem for transplant?
So TET2 is one of those mutations that we talked about. And TET2 by itself doesn't really influence things very much. It would depend on what else it's with and what the other characteristics of the disease are. So TET2 is not something that I would, it by itself, independent of everything else, would not have a very much of an influence. But again, it's what else is going on.
All right. And then I think this gentleman is asking a question that I've heard from a number of patients. Why is it so difficult to learn the outcome of clinical trials? As an AML transplant survivor, I participated in 3 clinical trials over 5 years ago and have no idea of their success.
Well, I would call the center where I was treated and get the result. Certainly, they owe it to people. Now, I would say that participation in a study 5 years ago, it's actually it's pretty questionable whether you'd have a result yet. Remember that for a study to have its result, all the patients have to be accrued, right? So you say, well, we're going to randomize 200 patients. You have to randomize 200 patients, and if you're patient number 10, you still have 190 patients to go. It can take a long time to accrue those other patients. And once those patients are accrued, then they have to be followed for a certain length of time to reach the end point. And once the endpoint is reached, then you have to go through all the data. There have to be audits to make sure all the data is accurate, reviewed. The statisticians have to go through it to summarize all the data. And then finally, only when the data is accrued, reviewed, and published can the data be released. And that's according to generally the rules of the game. So it may be that the final results of those studies just is not available yet. Now, having said that, if the results are done and the study's finished and the manuscript is written, then certainly the patients should be, the data should be made available to the patients as well.
All right, and then this final question is rather a general question. The person wants to know whether you have any suggestions about nutrition and what role that plays in the success of treatment. Excuse me.
So let me start by just being, a broad statement. We do know that patients who are either way too heavy or way too thin do more poorly with AML induction and with transplantation. And so patients who are, very obese or very underweight have poor outcomes. That's just a global statement. We do know that having obesity and diabetes increases adds to a comorbidity index, which means that outcomes of treatment are poor. Now, do we know that beyond also hypertension is a risk factor, another one of those comorbidities? And so it takes a long time, but almost certainly people who have high-fat diets, high-salt diets, take in too many calories, tend to get diabetes and tend to be hypertensive. And so all that does certainly contribute to poorer outcomes. Now, if you're trying to get more granular than that and talk about do people that take in a bit more whatever, vitamin C or vitamin D or something else, does that have any outcome influence? It's much harder to see that. But studying diet and studying nutrition is a really hard thing to do. And some people, roll their eyes, why don't you know? But taking dietary histories that are accurate is very difficult and in the past been shown to be highly inaccurate. And so you have to do careful feeding studies to try and get at those results. We do know that during the course of treatment that, for example, people are undergoing transplantation, if they do not have any GI intake, there's more damage to the GI tract during transplantation. And so we do encourage continued oral feedings during the procedure to allow for more rapid recovery. The literature on nutrition is, I can't possibly begin to summarize it in an answer to a question. I think that we really rely heavily on our, when I attend on the transplant service at the Hutch, I have a team with me. I have a pharmacist, I have a dietitian, and I have, the physician's assistants and the nurses and the schedulers. But if I didn't have the dietitian and the pharmacist with me, I wouldn't do nearly as good a job in taking care of my patients. So they really do play a key role in the course of transplantation.
And with that, I'm afraid our time is easy, and we're going to need to wrap up. Thank you again, Dr. Appelbaum, for a very enlightening presentation. And thank you, the audience, for some really excellent questions. We got some wonderful additional information as a result. As a reminder, this presentation was recorded and the recording will be available in the Video Learning Library on BMT Infonet's website next week. We'll send everyone an email when it's ready to view. Have a wonderful rest of your evening, and please do let BMT Infonet know if we can help you in any way. Good evening.